So, good afternoon, everybody. Welcome to another session of One Among You. So, this is the sixth episode of One Among You series. Now, let me introduce about the program. Let me talk about the program. This One Among You series is an initiative by Epistate Health Singapore. Where we discuss the cases done by our outstanding dentist. So they're like a short endo course or short endo talks where the eminent dentists who have executed the case wonderfully will share important tips and tricks of endodontics, rather clinical endodontics with you. I am Dr. Niharika, your host for today. And today our speaker is Dr. Abhay Shukla, the renowned Dr. Abhay Shukla. I think most of you must have heard the name of a very uh, nice WhatsApp dental group. It's WhatsApp Dental Association, and Dr. Abhay is the mastermind. I request all of you to join the group. It's one of the finest endodontic groups existing these days. There are so many good speakers in the group, and they purely share dentistry, clinical dentistry. So it's a very nice group. And Dr. Abhay Shukla is the person who introduced the group. He's admin of the group. So let me introduce you to Dr. Abhay Shukla, the speaker of today. Dr. Abhay Shukla is a dental surgeon and has completed his PG diploma in advanced aesthetics and restorative dentistry from London. Dr. Abhay Shukla has completed his dental surgery, has graduated from Government Dental College, Raipur. He has been practicing general dentistry, a high-end general dentistry, but he has also maintained a special interest in endodontics, restorative dentistry, implant dentistry from the very beginning of his practice. He is a renowned endodontist. He keeps in pace with the developing dental science and has continued his dental education and has been trained under various national and international mentors. Dr. Abhay is the first dentist to have dental operating microscope in private practice in entire Chhattisgarh. Currently, he maintains his state-of-art practice in Ambikapur, which is in Chhattisgarh, and has been visiting many clinics for root canal treatment and implant center. He is the chief mentor and conducts various and numerous hands-on courses under the name of Endo Pathshala across the country. So, Abhay Shukla, the stage, I would say, the screen is all yours. So, without more ado, let's welcome Dr. Abhay Shukla. Dr. Abhay, your voice is not visible. Your voice is not audible, sorry. Please check your mic. Your voice is not audible, Doctor.
Sir, you are on mute. Please unmute yourself.
Ah, am I audible now?
Yes, sir.
Yeah.
Okay. So let me get back to my presentation. So thank you so much, Dr. Niharika ma'am, for introducing me and giving me an opportunity for presenting a webinar over the topic retreatments or root canal treatments. So this is something we have been knowing each other since long, I guess. I was introduced to Dr. Niharika in the year 2017 in the KOL meet of Bombay Dental and Micro-Mega in Bombay. So it was an amazing meet, and I usually cherish those memories when we met, and we enjoyed a lot and we learned a lot. We shared a lot of things there, and from there to today, we are good friends, as well as we talk about topics, we discuss many things in between. So thank you, Dr. Niharika, for giving me an opportunity to share a bit of my knowledge, which whatsoever I have. So the retreatments, this is something which is बहुत बड़ा होवाक है लोगों के मन में. It's like people don't have so much of confidence while they are retreating a root canal treatment. When it comes to retreatment, people usually get scared off, and they think to bring down any endodontist into the clinic for the retreatment, or usually general dentists, they refer those cases to the specialist. It's good that they refer those cases, but retreatment is something which a general dentist can perform in his clinic, बशर्ते कि he has that expertise, he has that knowledge and skill. And today here I am to present some of my cases so that it can help you, some of my tips and tricks that can help you to improve your execution of the retreatment cases. So uh, let's start. So I'll be revealing some of the secrets, most of the secrets, I guess. Okay. So I'll be starting with my with the photographs of my practice. This is my practice. This is City Dental Hospital, Ambikapur. This is a small city where I actually practice, and these are the operatories. These are the chairs where I means this is something which is the best place to hang out. For me, it is the best place to hang out. So it is important that you have that attachment to your workplace. If you don't have that attachment with your workplace, you will try avoiding to go down there and do good treatments, right? So it is important to have a good aura. It's important to have, means everything should be good. So it always helps you, and it gives you and provides you the positive energy. And whenever you reach your office, when you see it, you actually get filled up with the positive energy, and you start doing things in a positive way. So it is very important that you have a neat and clean clinic and have good aura in your clinic. Also, the patients appreciate it very much. Uh, this is something which I established in 2022, and before that I was practicing in a small place that was merely 420 square feet. Now this has grown to around 2,500 square feet. We have 1,000 square feet more. For the expansion in the near future, we will be expanding, so we are thinking about that. So this my practice is around 4-chair practice, and my wife practice along with me. So we have chairs from different companies. My favorite company, the Confident chair is also available, as well as this is something which is my favorite part of my clinic, my setup with the dental microscope. So it is very important that any person who is into or who wants to get into retreatments and good root canal treatments and quality treatments, it is important that you have magnification in any of the form. Either you can have what either you can have either you can have a microscope, or you can have a loop. So it is important to understand that you can see in the right side of your screen, I have shared you the canal anatomy complex. So you should remember that root canal treatment is not a two-dimensional space. It is a three-dimensional space that should be cleaned thoroughly. That means you should be able to clean every nooks and corners so that you get the predictable results at the end. Okay. So it is important that you start using magnification today. If you haven't started, you are, प्रोकास्टिनेशन कर रहे हैं, नहीं आज नहीं लेंगे, कल नहीं लेंगे, परसों ले लेंगे, नरसों ले लेंगे, प्लीज stop doing that. You know, whatever I am today, magnification has a big role over it. When I started using microscope, it was like, means people used to laugh at me. But today, that has become a need, a necessity, a most important thing and part of your clinics. So it is important that you start using magnification in either of the form. Either you can go for a good loop, either you can, or you can go for a good microscope. So also why it is important, you know, means why is it important to have magnification? It's a small video through which I would like to tell you how important and how much big role the magnification plays while you are retreating the case. Okay. So this was the retreatment case where I started, and while I was going to obturate the canal, I was actually going to use the paper point and obturate my canal. Just see there, you can see the stick gutta percha. So that stick gutta percha is, that can be dangerous because that can actually keep holding lots of microorganisms. Right? It is important that you look into it, peek into it, and use the ultrasonics. And through that ultrasonics, you clean each and everything, every bad thing inside the canal and take it up. It is important to take it, means, you know, means all the bad things to take out rather than what you in. What you take out, right? Everything is clean now. Ultrasonics has a big role while you are retreating. Ultrasonics plays a big role. Yet again, using paper points to dry the canals. And then once it is done, it's time to obturate. This is how I obturate. Warm vertical continuation. This is continuous wave technique. I use continuous wave technique, and at last you can see the final results of the obturation. And the radiograph, the complete radiograph, which verify completed with a 3D cleaning obturation. So it is important to understand the success versus failure in endodontics. You know, means it is something which is very vague in endodontics. Success and failure is very vague. Okay, success is defined by the goals established to be achieved. So the goal in endodontic treatment is to heal or to prevent the disease, right? Success in endodontics is very ambiguous, and we are very stringent, you know, means we are strict. Then we need to understand that clinically as well as radiographically, normalcy is something which is important. But if we are lenient, and if we see that the tooth is something which is clinically normal, we can call it success. We can call it success. So it's better we avoid using term success or failure in defining the outcome of endodontic treatment. Okay, you might have seen so many cases, guys, when patient has got treatment somewhere else, and those root canal treatments are into the mouth, and those are running strong since so long, 10 years, 15 years, and radiographically you see short obturations, coronal micro leakage. Even after that, the tooth is something which is very strong and playing its role in the patient's mouth functionally. But uh, uh, usually if you ask the patient that you should get it retreated, this is something which the patient will be so skeptical about, and he will get skeptical, and he will say, and he will actually neglect, and he will not get it treated. So it is important that you make them understand that the tooth which he has got the root canal treatment done somewhere else can create a problem in the future. So in case if he or she is getting, means if he wants to get a crown changed or something like that, a prosthetic change, it is important that you do the retreatment in those cases, and do not avoid root canal treatment, as because in the future it may get infected, and the complete means burden will be on your head. जो है आपको पेशेंट बोलेगा कि आपके करने के बाद, आपके काम करने के बाद इसमें सिम्टम्स डेवलप हो गए हैं. So it is very important to understand that. So we should actually evaluate the success of RCT. So clinically, if we see, then there should be no tenderness to percussion or palpation. There should be no mobility, no subjective discomfort. Tooth having normal form, function as aesthetics, no sign of infection or swelling, no sinus tract or integrated periodontal disease. Radiographically, when we see, then the normal and slightly thickened PDL space will be visible. Reduction of elimination of previous rarefaction will be visible. Normal lamina dura will be visible. No evidence of resorption will be there, and a dense 3D obturation of the canal space. It is important that histologically there should be absence of inflammation, regeneration of periodontal ligament fibers, presence of osseous repair, repair of cementum, absence of resorption, and repair of previously resorbed area. But it is impossible to evaluate every case histologically. You can actually evaluate clinically and radiographically. So if you want to go histological, you need to take out the, means you have to perform a surgery, you need to take out a sample of bone, and then you have to send it to lab for the examination. So you cannot evaluate histological, it is not practical. So it is important that clinical and radiographic science and views, everything is something which will tell you the success of RCT. So why retreat? Why should we retreat? The thing is, patients nowadays, they are, very much having high expectations with the dentists, and they want to retain their natural dentition, and they are very reluctant to the tooth extraction these days. We should give a second chance to a failed RC treated tooth, right? And the root canal treatment success rate shown in different studies varies between 70 to 95%. An assessment into the standard of the root canal treatment in England and Wales, for example, showed 97% of the molar root canal treatment and 84% of the canine and incisor root canal treatment had the technical difficulties. So due to those technical difficulties, sometimes the root canal treatment get failed. So obviously there is a contradiction between what is achievable and what is actually achieved. Okay, so why does RCT fail? The RCT fails due to various reasons. The most important thing is biological failings. There can be cyst, root fractures, incorrect diagnosis, and the primary treatment, foreign body reaction, healing with scar, neuropathic problems, as well as economic constraints. So we have to focus more on the biological failings, that is infection. So what is biological failing? You can see here that there is an electron microscope image of dentinal tubules. This is an infected dentinal tubule, and it is visible that so many bacteria has clogged that space, that dentinal tubules. So it is important that the we need to understand that most common reason for the failure of the root canal treatment is the microbial infection, right? They may have persisted after the primary root canal treatment or might have reached the apical area through the micro leakage. So never ever underestimate the micro leakage. People, dentists, especially the general dentists, they actually underestimate the micro leakage. That can lead to the failure in the future. So it is important that you achieve hermetic seal both apically as well as coronally. It is very, very important. So what is the looking all these things, what is the rationale of the retreatment? So the main reason for the failure of primary root canal treatment are biological. Therefore, the rationale of retreatment has to be based on the sound biological objectives of elimination and future exclusion of infection from the canal system, right? So what are the causes of biological failures? As I actually told you that we will be focusing more on biological failures. So we need to understand what are the causes of it. So the first thing is poor aseptic technique. There was a survey where, and that was conducted in UK, and it was found that more than 70% of all dentists surveyed that they don't utilize rubber dam for any procedure whatsoever. Okay, so practitioners that do not use a rubber dam concomitantly tend not to use biologically active irrigants. Know what are the biological active irrigants? That so it is important that you actually isolate your tooth with the rubber dam and use the correct irrigant for the disinfection of the canals. So people also are into, means like using incorrect irrigants. They actually believe that irrigating with normal saline, 2% CHX, distilled water, and betadine can actually eliminate everything from the canal. But it is something which is a big myth, and they are actually into a big delusion. So the thing is, you can no doubt 2% CHX, the chlorhexidine, and betadine has antimicrobial activity, and they can help in disinfection, but they don't have what, they don't have the organic dissolution property. They are not able to dissolute the organic content of the canal. Okay, so it is important that we use the best irrigant, that is chlorhexidine, and that should be in the percentage of 5% to 6%. Okay, so stop using normal saline and distilled water. It is not going to help you anyway. That's because you can see here this image. This is the image of isthmus. Okay, so it is important that your whatsoever irrigant is, it should reach every nooks and corners. So this isthmus area is something which cannot be mechanically debrided by the help of files. So it is important we have a certain kind of irrigant which has lesser surface tension, and that can actually penetrate deep into every nooks and corners of the root canal system. Here you can see the isthmus area that should be clean. Okay, so this is the isthmus area, this one. This should be clean while you are actually treating a root canal. In case if it is, means it remains unclean, that can lead to the further failure in the future, as because it will carry, and it will hold down the infected portion where the microorganisms will be thriving, and those microorganisms can actually lead to the failure in the future. So it is important to understand, sometimes it is means people who are not having good skill set, they are unable to prepare the canal till the length. Usually you need to understand that the apical 1/3 of the root canal system is also known as critical zone, as because it contains so much of typical anatomy, like the lateral canals. You can see here I have filled up the lateral canal. So the apical ramifications, the apical ramification, yeah, apical delta, in case if it is left uncleaned, it is going to fail sooner or later. And the isthmus, you can see the isthmus, and I have shown you already the photographs of isthmus earlier. So this is something which is the image which I have taken from one of the books, my favorite books. You can see the root canal filling material. If it remains short, the last area, the most critical part of the root, that is the apical third, which has so many of complexities like apical ramus, like apical delta, like lateral canals, that get left untreated, and that carries down the microorganisms, and those microorganisms will sooner or later means will increase their colony size, and there will be persistent inflammation in the apical area, and that will lead to the failure of a root canal treatment. So it is also important to understand that we sometimes miss the canals. Most of the times general dentistry, in general dentist, what I have seen is we usually make a mistake, and we don't have the proper knowledge of the anatomy, and due to that we usually miss cleaning the second or the third canal, and it may lead to the persistent bacterial inhabitant there, and it can lead to the failure in the future. So it is important that we have a sound knowledge of anatomy, and before retreating the tooth, the clinician must be prepared for the added complexities in the retreat cases. Now, maxillary first molar contain two canals in mesiobuccal root in approximately 78% of the teeth. Mandibular incisors have two canals in over 40% of the cases. Mandibular first molars frequently contain four canals. So, usually I have seen, whenever I have been retreating mandibular first molars, I see people leaving the disto buccal or distolingual canal, and it is very, very common. We need to understand, guys, that mandibular first molar has got four canals in 99% of the cases, 99 to 100% of the cases, I guess. So there are some extra canals also. So what I जो भी मैंने पहले बताया है वो extra canals नहीं है. They are not extra canals. They are actually considered into the anatomy. Extra canals are like distolingual canals in the mandibular first molar, that is known as radix entomolaris, and mid-mesial canal, mid-distal canal are usually missed during the primary root canal treatments. There are procedural errors like ledges and zipping. This is ledge formation. There is zipping, apical transportation. There are lateral perforations. This is one of the lateral perforations. One of the referred cases that I actually treated. So there was a lateral perforation at the apical end. In that case, what happens? You are unable to, and there is a broken file as well. So usually dentists are not able to clean the critical zone, that is the apical 1/3 of the root canal, and it actually leads to the persistent microbial flora inside the canal. It will lead to the inflammation. Means there will be like continuous release of endotoxins and exotoxins by the bacteria in the apical area. It will lead to the inflammation, and it will lead to the failure of the root canal treatments. Sometimes we actually perform poor obturation. Now it is important that I told you that your hermetic seal is something which is very important. so that you actually avoid micro leakage. You never ever underestimate the micro leakage. So it is something which is very important. So you can see here, this was the retreat case which I actually performed. You can see a wonderful three-dimensional filling of the root canal, a dense filling of the root canal, where the further flourishing of the bacteria will be not possible. So we have to make it possible, and we can definitely do it. This is something which is poor obturation. You can see here that you can see complete root canal filled up hai, white lines. I always say that root canal treatment is not about getting good white lines. ओके, पीपल थिंक लाइक कि जो है मैंने गुड व्हाइट लाइंस बना दी, मैंने जो है बहुत अच्छा जो है ऑब्चुरेशन कर लिया, उसका फोटो डाल दिया, सोशल मीडिया में डाल दिया, बहुत अच्छा रूट कैनाल ट्रीटमेंट कर दिया. इट्स नॉट लाइक दैट. You can see here, you can see very good white lines will be visible, and you know, means this is something which is important, that you actually clean the root canal three-dimensionally and obturate it three-dimensionally as well. So पुअर कोरोनल सील, ये जो है सबसे बड़ा, मीन्स इट्स टॉपिक, एक लंबा खुद का अपना एक बड़ा टॉपिक है. मीन्स इसको एक दिन इसी में निकल जाएगा अगर मैं ये बताने लग जाऊं तो. इट इज इम्पोर्टेंट दैट वी नीड टू अंडरस्टैंड पुअर कोरोनल सील कैन एक्चुअली लीड टू द फेलवर. ओके, so the good root canal treatment with good coronal restoration achieves the best outcome, whereas poor root canal treatment and a poor coronal seal may lead to failure. You can see here there is poor coronal seal, right? And it failed. This patient came to me and I performed a retreatment over it and sealed the coronal area properly with the help of composites. Either you can use composites, you can use GIC, whatever you are using. You can even use amalgams, no doubt, but it should completely seal the coronal area so that there is no micro leakage of the saliva and the microorganisms along with that into the apical area, and that will lead to the failure if you leave it poorly sealed coronally. Okay, so when to consider referral, this is something which a general dentist should understand. Okay, it is very important. So complexity of the treatment is greater than the क्लिनिशियन एक्सपर्टाइज. कहने का मतलब ये है कि अगर आपको ये लग रहा है कि ये मेरे एक्सपर्टाइज या the instruments that you are using, the technology that you are using, you are lacking somewhere there, you should not touch those cases. You should actually refer to the people who are eminent in doing such kinds of cases, who have those equipments and skill set, and that is the best thing to do. So kindly refer if you can't treat. If it is very complex and it is आपके हाथ से बाहर की चीज है, तो प्लीज उसे छूने की मत, मतलब आप उसको टच ही मत करो ऐसे केसेस को. And when the clinician has retreated once and it has failed, so better है कि जो है अब मैं फिर से retreat करके देखूं और फिर मैं जो है ट्रायल करूं और फिर जो है, it's not like that. Just send the patient to the person who is eminent enough. Okay, so now it is important when we are doing or performing the root canal treatment, we remove the crown. Okay, and also sometimes it is not at all important to remove the crown. Okay, I will tell you where to remove and where not to remove. For the removal of the crown, we will be using burrs like, this is metal cutting carbide burr. This is from SS White that I use. So what you actually do is you cut it through the crown के mid part से आपको उसको cut करना है, and it should touch the sound portion of the tooth. It should not go beyond that. Okay, so when this metal cutting carbide burr, it is actually used in cutting the metal ceramic crowns. Now this is something which is a jugaad that I have in my clinic, that is a modified coupland chisel, या फिर आपके पास में अगर coupland elevator भी है, so that is something which is helpful. You have to hold it in this way, and you just have to give. You have to engage it the portion at the portion where you have made the cut, and at the 90 degree, and just give a twist, a twisting force apply kariye mesially and distally. The crown will get debonded, decemented immediately. Okay. Now, remember that recently performed primary root canal treatment and a well-fitting crown over it must not be removed. It should not be removed. It is unnecessarily removing. You know, means जो है patient का पैसा भी बर्बाद होता है, time भी बर्बाद होता है, and it is something which is, you know, very traumatic to the patient. Okay, so it is, and at last it is not conservative as well. So it is important that you don't remove the crown in such cases. Okay. So while making excess opening, we need to understand that in the retreatment of the tooth, you know, the excess opening gets deferred or जो है वो थोड़ा अलग हो जाता है. While in the primary root canal treatment, we start from here, okay, and we get a drop, okay, and then we actually expand it, and then we do the refinement with the help of what, the scalar tip or ultrasonics. And then you peek inside and look over the dentinal map and find the canals. Okay, you insert the K files and find the canal. But this is something which is not at all applicable over a retreat case. Here you first remove the crown. You actually remove the coronal gutta percha with the help of ultrasonics. Then you peek inside the canal chamber. The chamber has got 3 dots, 2 dots. जितने भी number of the canals होंगे, उसके हिसाब से the number of dots, pink dots, will be visible. Okay. So it is important to remove the gutta percha as well. So you have, depending upon the obturation techniques followed during the primary root canal treatment, we can, you know, use, like, you know, in the single cone technique जो है ये हथियार ही बहुत बड़ा जो है रोल प्ले कर देता है. ये है अपना H stream file. जो H files हैं, if you have H files in your clinic, you can actually take it out in one go. You have to engage it inside the you know, the cone, and you just have to pull it outside. Okay. And in case if it is not tall, it is not getting removed, then you can use files which has a cross section like H files, that is retreatment files that I use are from Bombay Dental, or one shape files. They are also capable of doing the same. Okay. So removing dense obturation, it is something which is very difficult, very tough. जहाँ पे single cone obturation होगा ना, it is very easy to do and remove. But while you are removing dense obturation, you need to understand that you have to divide the system, the part, into 3 parts. You know, the coronal 1/3, where I use RM files. These are files which I had stocked in good number from Bombay Dental, but nowadays they are not selling. They are not into selling this. These are the files from Micro-Mega, so they have stopped selling it. But this is something which is my favorite file. So what you actually do is कि जो है इसको you have to put inside the coronal 1/3. You have to look inside. First of all, you have to look inside. Okay, जो है जैसे ईगल जो है मछली को कैच करने के समय देखता है और फिर उसके बाद उसका ध्यान हटता है. You need to understand that. In the same way, you have to be very peculiar about while you are inserting this file into the system, into the gutta percha cone, or else this is something which is dangerous as well, as because this file has got good buckling resistance. Buckling resistance का मतलब क्या होता है? When you insert it, it doesn't get buckled up, means वो जो है मुड़ता नहीं है. It has a you can actually apply a good amount of force without getting it twist and turn. So it is something which is having good amount of buckling resistance. So ये जो है दो धारी तलवार है, जो है it can actually lead to the formation of ledges, as well as that can also break inside the what? Inside the canal. It can actually break inside the gata parcha cone, and it will make your life means life hell अब जो है वो और मुश्किल बना देगा आपके retreatment. So it is important that you use it very cautiously, and while you are peeking inside through the microscope or magnification, that will become easier. Okay, so it is important you just make it, means you have to go inside, you make a hole through it, and then when you are in the middle one third, you can use the retreatment files which has got the cross section, in the form of H files. जो अभी मैंने बताया कि H files की जो cross sections होते हैं उससे मिलता जुलता cross sections होते हैं इनके, and it removes the gutta parcha very easily. Yet again, while you are into the middle third, it is important to understand that you peek inside and view everything. Means when you are inserting the file, you should be, into the gutta parcha. Means you should not be here or there. Now, these files also have good buckling resistance, but they have bit of, flexibility as well. The reason that I have been using it in the middle one third. Now, you need to understand that the apical one third is the most dangerous part. Here there are various twists and turns, and us turns and twists may you don't have to jump with this file. The file which I've been telling, this file, ये file आपको apical one third में use नहीं करना है. So what you need to understand, you need to use a file that is able to make a hole through the remaining gutta parcha in the apical area, and it should be under your control, and that can be any of the hand files. जो है हाथ से अगर आप कोई चीज करोगे, tactile sensation आपको मिलेगा. जब tactile sensation मिलेगा तो आप वो पता होगा कि कहाँ तक जाना है, कहाँ तक रुकना, कहाँ पर रुकना है. So it is very important. But when you are using such kind of means the rotary, you are not having that tactile sensation, and due to lack of your tactile sensation, what can happen, you can actually perforate, वो एक नया सिर दर्द हो जाएगा. So you should be using a hand file only while you are negotiating the apical one third. Now see, this is something which I am telling you with my experience. By my experience, I have done mistakes in my while I'm doing. I've done so many retreatments, uncounted. मैं गिनती नहीं कर सकता कि जो है मैंने कितने retreatments किए होंगे. But the thing is कि I have learned by making mistakes. So it is a big no that I am telling you. You don't have to use the coronal this rotary file until and unless you make a glide path. Okay, you can say, or you have scouted the canal through the through the gutta parcha, the remaining apical third of the gutta parcha. Okay, so now the best thing to use in the apical third is K file. शायद मुझे ऐसा लगता है ये इससे बड़ी डिस्कवरी और इस दुनिया में और कोई नहीं हो सकती. मतलब ये दुनिया की सबसे बड़ी डिस्कवरी है 10 नंबर K file. दिस इज समथिंग, ये रामबाण है, रामबाण. आई कॉल इट अ रामबाण. जो है हर जगह, एवरीवेयर, जो है जहां आप मुश्किल में फंसते हो, आप सीधे 10 नंबर K file लेते हो और वो आपकी सारी मुश्किलें आसान कर देता है, सारी मुश्किलें. So it is something which is very important, and you need to understand that 10 number K file is the best file to be used in the apical one third. In case if you are not able to, means it is something, it has got buckling resistance, but sometimes होता ये है कि वो apical one third में मुड़ जाता है. So what you can do is you can use a C pilot file, or you can use D finder files in those cases, and that can that can help you. But the best file for negotiating the apical one third in retreat cases, those are these 10 number K file only. Okay, so keep a good number of 10 number K file stocked in your clinic. हो सकता है कि you are able to negotiate, you are not able to negotiate with a single file. You need it, you know, means again and means एक box, दो box, कभी कभी तीन box भी जो है खत्म हो सकते हैं. You need to have that patience. So it is important that you use 10 number key file. Okay, and then once you have prepared the glide, okay, and you have established the, you know, working length, then you can definitely shift to the rotary files. Any rotary files, जो भी आप rotary files अपने clinic practice में use करते हैं, कोई particular rotary files मैं उसका नाम नहीं लूंगा, लेकिन whatever rotary files you are using, you can use that, and that should also be used cautiously. धीरे धीरे patience के साथ में you have to negotiate the apical 1/3 and remove the gutta percha from there. Okay, so I would like to share one of the cases. One of the cases video. So here's the case video. So you can it is visible that you know, means I'll be removing the crown. So see, here I am removing the crown in the retreat case, and I have been using what, this is the this is the early the diamond burrs, and this is something which is which I am we are using this metal cutting burr. And once the metal cutting burr has made a, you know, जो है इसने अपनी थ्रो वो बना लिया जो है, उसके बाद you have to use the so now I have started using the ultrasonics. In this way you need to remove all the restorations from the coronal part. You clean it, then I have started negotiating the canals with the and removing the coronal GP with the help of RM files. These are the files from Micro-Mega. Okay. Once you do that, this is something which is endo flare files. जो है ये बहुत पुराना केस है. So like at that point of time I used to use these files. Endo flare files जो है for the coronal, you know, coronal removal of the, you know, GP I used to do. I used to use these files. So these are yet again, you know, this is R1, R2 files, the retreat files from Micro-Mega. After that, you have to use 10 number K file for the apical negotiation. Okay, and then you remove much of the gutta percha again and again. जो है you go धीरे धीरे बीच बीच में hand files का भी इस्तेमाल करते रहना है. जहाँ भी जो है आपको dead end मिला, you don't have to use the rotary files. You have to use hand K files. Okay. You clean it thoroughly. You continuously irrigate the canal. You keep cleaning, keep removing, yet again removing all the GP from inside the canal. While doing the retreatment, yet again we are using the rotary files. Okay, cleaning it again with, you know, means continuous irrigation is something which is very important. Okay, so now I've started using what, these are the you know, the regular rotary files that we use. That is the, I guess that was a 2-shape file. You clean it. You again, you know, use the K file in between. 10 number K file, the best friend of an endodontist. Okay. And then you establish the working length. This is something where I am establishing the working length. See, this is the working length established, getting established. Once the working length is established, that means जो है आपने gutta percha को पूरा means you have prepared a glide path through the gutta percha, and then the regular files that you actually use in your. चाहे किसी का भी हो, that was a two shape file which I am using here. Yet again for the apical patency check, बार आपको you have to check दूसरे canal में you have to shift, and then you have to check the working length, and then use the regular files that you use inside in your clinic. Okay, and then again clean it thoroughly. Like this, you have to remove every bit of the gutta percha from the canal, and then after cleaning, in case if you are means sometimes you can perform single visit, or in sometimes you may have to give calcium hydroxide dressing. It is very important that we give calcium hydroxide dressing, as because the calcium hydroxide makes sure the killing of the bacteria, the stubborn bacteria like Eficalis from the apical area. So that is something which is very important. So for me, calcium hydroxide dressing for at least 7 days is a must while you are retreating a chronic apical periodontitis or any chronic case. So it is very important to do that, as because क्या है कि जो इफिकैलिस है उनके जो बायोफिल्म्स हैं, समथिंग विच इज अपने बायोफिल्म से एडहेयर्ड रहते हैं डेंटाइनल ट्यूब्यूल्स में, एंड इट बिकम्स क्वाइट डिफिकल्ट फॉर द इरिगेंट्स टू रीच and to remove those biofilms from the apical area. So it is important that you use calcium hydroxide dressing for 7 days at least, and then conclude the case. Okay, so I'll be starting with the cases. Here's the now this is something which I am going to tell you about the selective retreatment. It is not at all जरूरी कि जो है आप हमेशा पूरा retreatment करें. You can be selective in that as well. So but that for that selective retreatment you have to be selective. जो है आपका case selection सही होना चाहिए. So this was the case where the patient came for the primary root canal treatment, and the name of the patient is Dr. Tamrakar. He is a retired CMHO. ये मेरे लिए एक nightmare बन गया था ये case. So that's the reason I am sharing it with you all. This was a referred case. अब कोई referred किसी जो dentist द्वारा refer किया हुआ case है, so it becomes a big burden and a big responsibility as well. So you need to understand that no भैया इसको जो है सबसे अच्छा चीज means extra pressure of giving the best होता है ना. Then what happens जो है I found extra mid-mesial canal over this case, and then I obturated and sent him back. After that, what happened? Patient को I had given crown as well. And then patient means after giving the crown, patient phone करता है एक हफ्ते बाद और बोलता है कि sir there is a pain, मतलब there is it's still paining. It's like means जब मैं चबाता हूँ तो वो pain करता ही है, means I am not able to chew from that side. So it was like I thought that it might be due to sealer के extrusion की वजह से भी it can sometimes pain. So it is something like means आप जो है उस चीज को neglect करते हो, बोलते हो कि वो maybe pain जो है थोड़ा बहुत होता है. In those cases you can actually avoid it. आप जो है थोड़े दिनों में वो ठीक हो जाएगा. Then the cause was actually attributed to the sealer extrusion that goes by the time, and जो है मैंने बोला कि थोड़े दिनों में वो ठीक हो जाएगा. Patient called 1 month later. Then he said that pain is still there, and it goes and it comes and goes. Okay, so I thought immediately that something wrong was there, and I recalled the patient. Now it is important to understand that in acute cases, in case if the patient is having pain for more than 2 weeks, in case if the patient is having pain for more than 2 weeks, you need to recall the patient, and you need to means review it कि हुआ क्या है, क्या प्रॉब्लम है, ऐसा क्या मैंने किया है, कहीं ना कहीं कोई ना कोई गलती हुई है जिसकी वजह से acute cases में अभी भी pain persist कर रहा है. As because okay, someone is actually can you mute someone is actually Speaking from the other side. Ma'am, Niharika ma'am.
Yes, Abhay. Yes, Dr. Abhay.
Ma'am, someone is actually speaking, I guess.
Yes. I request all of you to mute yourself, please. Yes, please carry on, Dr. Abhay.
Okay, so the something wrong was there and recall the patient. Now, in acute cases, I told you that more than 2 weeks, if the pain persists, then you need to recall the patient and you need to review it. कि हुआ क्या है, क्या गलती हुई है, and in chronic cases, if the patient persists for more than 6 weeks, then it is something like fishy. You have to reconsider the case. You should recall the patient immediately, and you should consider retreatment or something like CBCT or retreatment, something like that. Okay, so here was the case. जो है जब पेशेंट मेरे पास में आया, आने के बाद I took an X-ray, and what I saw was there was some discrepancy in the obturation of the mid-mesial canal. Also, I was able to see the fragment of file in the mid-mesial canal. So वो मुझे click किया, and then I actually sent the patient for the CBCT. Now, in CBCT also means we were not able to, my radiologist was also like means she was like I don't see any problem in this case. Abhay, I guess there is something your obturation is something bad or poor. You should reconsider retreating this case. But in the coronal section, when I saw that there was something fishy, and I saw that there was means some part of the some remnant of the apical area which was left in the mid-mesial, that might be the cause of the pain. So I decided to selectively retreat the case. What I did was I retreated only mesials, and mid-mesial had a separated file. I showed it in the previous X-ray. So I removed it with the help of ultrasonic tips, negotiated the mid-mesial up till apex, gave the patient calcium hydroxide dressing for next 7 days, and boom, patient was absolutely gone. Patient was like means Abhay, I don't have any kind of pain since 1 day. Means first दिन से ही जो है मेरा pain चला गया. So that happens, and the ultimately obturated, and I called it the patient after 7 days, and I ultimately obturated and concluded the case. This is the cone fit. You can see only the mesials was treated, and you can see the mid-mesial canal that was completely negotiated until the apex. So this portion was something which was left behind, and it was the cause of continuous irritation and pain. Okay, so that may happen. Now I'll be concluding the cases. जो जल्दी कर देते हैं. And this was the case which I performed in the year 2014, and you can see there is separated instrument periapical radiolucency. This was a hopeless. While you have to probe your periodontal probe. While I was probing in the mid distal and mid mesial and the buccal aspect of the tooth, I was getting more than 10 mm of pocket and bone loss. So it was like we had to make aware the patient that I will try my best, and in case if everything goes good, definitely we can save such a tooth. But see, this was the means after giving the calcium hydroxide dressing, and this was the X-ray taken on the day of obturation. Okay, what I did was I waited at least for 1 year for the crown. In this case, this X-ray is taken after 1 years of waiting. In case if I see proper healing of the root canal, then only I will be going for the crown in this case, or else we will be extracting the tooth. So the patient came down after 1 year for the crown, and we saw each and everything radiographically, everything was healthy. And fortunately, this patient came after, means I treated it in 2014, gave the patient crown in 2015, and she came on Saturday, and you see that the zirconia crown is intact and the root canal treatment is working flawlessly. So it's going to be like, I guess 11 years, 10 years, I guess 10 years, follow up of this case. So it's standing and it's working fine functionally. You're doing everything for the patient, and patient is so happy. Case 3, this was a very recent case where there was a broken instrument in the mesial canal. There was almost a perforation, as because the treating dentist wasn't able to find the root canal, and he was, searching the root canal everywhere other than the root canal area. Okay, so it was getting, it was on the verge of getting perforated, but it wasn't perforated. And then this is the, means I removed the broken instrument, removed the gutta percha, and then, gave calcium hydroxide dressing to the patient. And also this patient had, sinus opening as well. So the primary sign of healing was visible after 7 days. So we decided to obturate it, and we obturated it with the help of warm vertical condensation. And this portion, what you are able to see is the composites. I used composites to fill this area and seal it coronally. And this is something which is the post, means after giving the crown. So it is important that when you are giving crown, so it should be very fit, and there should be no micro leakage through the crown. So it always, you need to, always recheck and ensure the fit of the crown, with the help of X-rays. So it is, you never should avoid taking X-rays after placing the crown. So this was the case 3. Now the takeaway points, you need to give attention to every details. If you are missing the details, you are means आप बड़ी मुश्किल में पढ़ने वाले हैं साहब. And it is important that we read the radiograph and we discuss with the patient. Okay, and we should question ourselves कि मैं ये कर लूंगा, नहीं कर पाऊंगा. अगर कर लूंगा तो करके दिखाना है. In case अगर नहीं कर पाऊंगा तो please refer. Now plan every step and execute accordingly. Person who is failing to plan is actually planning to fail. So it is something, every step of yours that you are going to execute should be planned prior to it. In case if you can write it down or pen down it will be the best thing to do. So write it down कि मैं इसके बाद ये करूँगा for the beginners who are actually, who want to deep diving into retreatment cases. So you should pen down everything, every step, and you should execute accordingly. Now, the most important thing is patience. Patience is the only key to success. Believe me, sometimes I feel like, yeah, better we should have extracted this tooth and placed an implant over it. But no, this shouldn't be your agenda, as because you, being a conservative dentist, I have always been, into like saving the tooth for the next 10 years, 5 years, whatsoever. Means जो अगर 5 साल भी जो है, we can give that tooth a second chance. Then उसमें कोई बुराई नहीं है, as because the patient means, patient can wait for the implants, and we have to discuss it thoroughly with the patient. The patient should know about the prognosis of the case, and after that the decision should be made. In case if he wants to get it extracted, definitely you can go for extraction. As because if the prognosis is compromised, then you cannot do anything, you know. The patient जो है कह रहा है नहीं 5 साल चलेगा, नहीं मुझे नहीं चाहिए, मुझे जो है अगले 20 साल के लिए फुर्सत होना है या 15 साल के लिए फुर्सत होना है, मुझे ये सब चीजों की जरूरत नहीं, तो फिर जो है you can definitely go for extraction. But in case if he says yes, then definitely go for retreatment and the restoration of the tooth. Accommodate magnification in any form today itself. So अगर आप प्रोक्रेस्टिनेट कर रहे हैं, आज नहीं लूंगा कल ले लेता हूँ, इतना पैसा कमा लेता हूँ उसके बाद ले लेता हूँ, तो आप बहुत बड़ी गलती कर रहे हैं. Immediately buy a good loop if you can't buy a microscope. So buy it today. So at last, success is a process. Okay, nobody in this world became successful in a day or a month. It takes years of hard work and dedication. So for the budding dentists, it's like, please believe in yourself, keep doing hard work, and with complete dedication and devotion, you will definitely get success one day. Have patience for that. आज की generation में patience नहीं है, मैंने देखा है. They are very impatient. They want to become big very soon, quick money. So it's not like that. You need to understand that आपकी जो जड़ें होनी चाहिए वो बहुत स्ट्रांग होनी चाहिए. जब जड़ें स्ट्रांग रहती हैं, कोई आपको हिला नहीं सकता. आप जो है सक्सेस के जो है उस पोजीशन में पहुंचने के बाद भी जो है आपको कोई हिला नहीं पाएगा. So it's important that you do hard work with devotion and dedication. Thank you. Thank you so much. From where?
You're on mute, ma'am.
Yeah. Yeah, thank you so much, Dr. Abhay. It was a wonderful presentation. And I request everybody, if they have any doubts, please feel free to post your doubts in the chat box below. And as far as I know, Dr. Abhay, he's a wonderful clinician. I keep seeing his cases. All the cases are done in an excellent fashion, executed so well with long-term prognosis, which is very good. You know,
Thank you. Thank you.
yeah. Welcome, Dr. Abhay. And
I'm
just want to
flattered.
know. Thank you. Just want to know, what is your treatment protocol when it comes to retreatment of teeth obturated with a bioceramic sealer? How do you remove that?
Ma'am, frankly speaking, I haven't done a single case where the patient has come with a failed root canal treatment in which bioceramic sealer was used. So I cannot give a view on it, but definitely what I know, what is my according to my information, bioceramic sealers are nowadays the whatsoever जो my bioceramic something easy to remove. It's like means a single cone obturation techniques we are actually performing. I myself am doing so much of cases where I am completely into single cone and bioceramic sealers nowadays, and they are excellent and they are very easy to remove. So what's the basic protocol, whatever basic protocols I have told you, you need to just follow that, and definitely you will get success in removing those as well.
Lovely, very, very true. And what is your treatment protocol when it comes to removal of fiber post? Can you please highlight that in short?
Yes, definitely. In case of fiber posts, what you need to do is you have to you can use piezos as well as in most of the cases you can use ultrasonic tips under the microscope, where it becomes very easy for you to remove the ultrasonic. Debonding. Debonding is something which is very easy with the help of ultrasonics. You can definitely debond.
Yes, and recently I have tried ultrasonics and rotary instrumentation both. I
Oh,
was doing a case 3 days back and I was not able to retrieve gatta perka. So I used ultrasonics. Then after
okay,
ultrasonics, I used my retreatment files. you
okay,
know
okay.
so it was a dense obturation like the one you mentioned.
So the buckling resistance of that file must be means outstanding, right? So it is
Outstanding.
very
Hmm,
important that
hmm,
like
hmm,
one file can definitely never remove those
hmm,
post,
hmm,
means
hmm,
durations which are very dense. So you
hmm,
should have files which has good buckling resistance. The one I
hmm,
actually told you, that is one shape file, or
hmm,
the, the files, the retreat files that the
hmm,
I'm using those files. Those are
hmm,
excellent.
hmm. And which ultrasonics tips would you recommend?
Ma'am, there are various combination of ultrasonic tips that I am using. Then some are from Cybron Endo, some are from Woodpecker, and I will definitely share you the list as because there are a number of endodontic tips, ultrasonic tips that I have.
Hmm,
EDC and
hmm,
14D,
hmm,
13D.
hmm,
There are so
hmm,
many, I use according to the, case. So those tips are something which are amazing. You can
hmm.
definitely use them and you can conclude the cases which are really very tough.
Yeah, so maybe next time we can host a talk of Dr.
Yes,
Abhay on ultrasonics. That's going to
yes,
be,
definitely. Yes,
yeah.
definitely.
And it's very
I
important for our, for the beginners and clinicians also. It's very useful.
yes. Yes, definitely, ma'am. And ultrasonics is something which has brought paradigm shift in the in the
Hmm.
field of
Hmm.
endodontics. And I
Hmm.
cannot imagine endodontics without ultrasonics these days. And
Hmm.
I
Hmm.
use ultrasonic tip and handpiece from these blue flex people. That is
Hmm.
U40, I guess. That name
Okay.
is
Hmm.
U40. That is something
Hmm.
is absolutely amazing piece. You
Oh,
should
wow.
definitely don't mind that buying
Hmm.
that. It's
Hmm.
nearly 18,000 or 20,000 rupees you get in from on the market. Earlier, the
Hmm.
ultrasonic tips means ultrasonic hand pieces, costed around 60,000, 70,000
Hmm.
rupees.
Hmm.
So
Hmm.
too costly. Nowadays the
Hmm.
prices have gone down, and what can definitely have those tips inside those handpiece in clinic and practice. So you definitely go with uh, those instruments.
Lovely. And just the last question. What is your recommended irrigation protocol or disinfection protocol?
My disinfection protocol in retreatment cases.
Yes, yes, yes.
Okay. So
Without
in
or
the
without activation. Hmm.
Okay, so in the retreatment cases, ma'am, it is important that we start using the hypochlorite from the very beginning. Okay, and we
Hmm. Hmm.
don't need to give any else any other irrigant a chance. It is very important that you have uh, hypochlorite in the most जो उनका उसका सबसे concentrated form होता है, that is 6%. 6% may you have to keep it and you have to start it from the very beginning. And
Hmm.
once you are getting in the apical area, every time you irrigate with the hypo only, with hypo only.
Hmm.
And continuous irrigation with the hypo. And at the end,
Hmm.
acha, in between that, you have to give calcium hydroxide dressing.
Hmm.
It is a
Hmm.
must. Without calcium
Hmm.
hydroxide dressing, I never
Hmm.
conclude
Hmm.
any kind of chronic case.
Hmm.
Okay, in the retreatment case, it is very, very important. As I
Hmm.
told that Calis is the bacteria which is
Hmm.
very
Hmm.
stubborn bacteria, and that those studies are there where
Hmm.
has been found that E. faecalis cannot be removed with the help of normal hypochlorite or chlorhexidine,
Hmm. Hmm.
betadine, or any kind of irrigant. So it is important that you give the patient a calcium hydroxide dressing for 7 days at least.
Hmm.
If you see
Hmm.
the primary healing, then only you
Hmm.
need to proceed with the obturation. If you don't see the primary healing, you need to reconsider and
Hmm.
revisit your root canals, and then you have to continuously irrigate again. You need to look out
Hmm.
that in case if you have under prepared the canals, sometimes mechanical cleaning is also not complete. So it is important that we actually complete the cleaning chemomechanically. So you need to increase the file sizes. In that case, I usually prefer, means my preference is 30 number O4 files. In pre-treatment cases, I go minimum with those files. Apical preparation, my master apical file is something which is 20 O4 in such cases. And in large canals, sometimes it goes up till 4504 or 50 number K files. After 4504, I don't use rotaries. I don't recommend rotaries. You should go for K files. And those cases, you should prepare. You should remove them. Remove the bacteria mechanically, and then chemically, you need to use calcium hydroxide again for 7 days. You see the primary healing, and then after primary healing you need to clean the canal with the help of saline and then hypochlorite. Yet again, for the hypochlorite, it is important that you activate the hypochlorite continuously with the ultrasonics. Okay, as because those cavitations you had that will able to, means with the help of ultrasonics, we are giving and providing the velocity to the irrigants. The kinetic energy is transferred, and we are giving the kinetic energy. And with the help of those kinetic energy, it is actually getting into every nooks and corner, and the penetration of the irrigant also means happens in the deep dentinal tubules, and it cleans the every bacteria from there. So it is important that we achieve good infection before operating, and ultimately after that I use EDTA at the end, liquid EDTA. And liquid EDTA के बाद फिर I used to clean it with the help of distilled water, and again I use hypochlorite, and then again at the end I use distilled water as my final irrigant. And then I obturate the canal with the help of sealer as well as the this gutta pacha.
Thank you, Dr. Abhay. That once again a heartfelt thank you to Dr. Abhay Shukla for delivering such an insightful and informative session on endodontic retreatment, which is quite needed in our routine practice. We are truly grateful that you accepted our invitation and generously shared your expertise with our online participants. And your knowledge and clinical pearls have undoubtedly enriched everyone's learning experience today. For all those who can't attend this live session, the recording of today's session will be shared on our YouTube channel and Instagram account shortly. So stay tuned. Link will be shared on the YouTube, on the Instagram account. In case if anybody of you have any further doubts, please feel free to contact us. We will be happy to assist you. I'm sure Dr. Abhay Shukla and myself, we both will be happy to help you out. You can us personally with your doubts. And additionally, as I mentioned in the chat box, we are issuing participation certificates to all the attendees. So kindly drop your name, email ID, and WhatsApp number in the chat box below so our team can reach out to you. Once again, thank you all of you for your active participation and online presence. We'll be back soon, another exciting episode featuring another eminent endodontist who's going to share their clinical expertise on relevant clinical topics in endodontics with you. So now to share a small token of appreciation from our side. Just a minute, please. Thank you so much, Dr. Abhay Shukla, for sparing your time and sharing your valuable expertise with us. Thank you so much. Thank you, everybody, for your time.
Thank you, ma'am.
Thank you.
Thank you.
Thank you. Yeah, please feel free to share your details in the chat box. All the participants who have shared their details will be issued certificate. We can't issue certificates without the details. So please share your details. Thank you once again. Thank you, Dr. Abhay.
Thank you.
We'll be in touch. Yeah, bye.
Yes,
We'll be in touch.
definitely we'll catch. Okay, okay.
Bye. Bye.
Bye. Take care. Bye-bye.
Bye. Take care. Bye bye.